Hi, I'm Dr. Rangi. I'm an endocrinologist and I practice in Sacramento, California. Today's topic is something very interesting, and you probably have somebody close to you or in your family or friends who has the condition. It's called diabetes. We are primarily talking about type 2 diabetes today, but there's other kinds of diabetes as well, out of which type 1 diabetes is the most common other kind. There are other conditions as well that can cause diabetes. For example, if you have certain medications or toxins that can affect the pancreas over time, that can result in diabetes, or gestational diabetes is another example. So let's talk about type 2 diabetes. Type 2 diabetes is very common. About 34 million adults in the United States have type 2 diabetes. And the interesting part is about a quarter of those don't even know they have diabetes. So these are high risk asymptomatic type 2 diabetes patients who are walking around with very high blood sugars and they don't have the diagnosis. So this is especially the area of my interest, where I wish to diagnose these patients earlier on, because these are the patients who are going to have long-term complications that can be prevented earlier on. Now, if you look at diabetes, it's 1 in 10 adults in the United States have diabetes. Now, if you come to prediabetes, another 88 million in the United States have prediabetes, and that is 1 in 3. That is another area of my interest, to find out how do we catch these prediabetes patients earlier on and how do we prevent these from progressing to diabetes. So I'll try to cover a few things here for you, because this is something very generalized approach of taking care of our patients. However, each individual patient needs their specialized care, and you must work with your doctor. This is not a recommendation for you. So when the patient comes to us, what are we looking at? We are looking at identifying what is their established complications of diabetes, if they have any, and if they do not have, how do we prevent complications from happening, and how do we keep their diabetes under as good of a control as possible with the correct use of medications that have least side effects that the patient can have. And by that, what I mean is least side effect of weight gain, least side effect of hypoglycemia or low blood sugars, and least side effect of any other conditions that can happen from the use of medications. Now, there's a common question that we get, if diabetes causes cancer, or is it related to cancer? And on the other hand, there's another question that comes out: do the diabetes drugs cause cancer? That's a topic for another time, but I will briefly cover it. It's primarily obesity or weight gain or BMI that is more than 30, which is associated with more risk of certain kind of cancers. And that could be because of their high amount of insulin in their system, which is endogenous, that their body is producing. We're not talking about insulin that is given from outside. There were some conditions, some studies that have questioned if the outside insulin could cause cancer. Certain of my patients have asked me that question as well, whether we should use insulin and if it's safe and if it can cause cancer. So my educational approach to those patients is that if you lose weight, if you're healthy, and if you can get active, I will not have to use those medications. Most of the medications have remote, rare cancer risk, and that too has been shown in animals, not in humans. So it's not generalized cancer risk that we can talk about. However, the point I'm trying to make here is that we have patients who have their own endogenous risk factors that are putting them at a high risk for cancer, that they could modify and decrease their risk before we introduce those medications that can be questioned for side effect of cancer. Now, going back to our topic of how do we approach these patients once we've identified prediabetes or a diabetes patient. First of all, I'd like to consider patient as the center of the treatment plan. We like to discuss all their concerns and figure out what their medications they've tried in the past, why that did not work, what kind of side effects they experienced, and what other treatment options could be better for them. And by that, what I mean is there are a lot of newer medications that are coming out in the market that have beneficial effects on the heart, they have beneficial effects on the kidneys, and they have beneficial effects on weight loss, which is not the target for therapy, but these are side effects that are very positive, and we should select our medications or drugs accordingly. So there's guidelines that are published by ADA, American Diabetes Association, in January of each year, and that guides us how we should be careful about what the studies have been published in the previous year and what evidence shows and how we should change our treatment plan. Based on that, I usually determine what my approach will be for all patients. There are guidelines that are determined by American Association of Clinical Endocrinology and American Diabetes Association. So most of these guidelines are very common, but there could be some differences as well, but then you individualize care to each individual patient and not generalize to all patients, and that helps us figure out which guidelines or which certain tools we can use for a certain patient. Now, going down to the treatment. Number one, nutritional and lifestyle changes cannot be understated. That is something all our patients have to understand. In our diabetes patients, majority of those patients with type 2 diabetes are obese. Not all of them. There's also a strong genetic component in type 2 diabetes as well. So usually what we educate patients is if you do stay active and you exercise regularly and keep your weight in check, you can prolong that duration when the diabetes is diagnosed from prediabetes, or you can delay overall the development of prediabetes as well. So these are modifiable risk factors that can be changed based on your behavior, based on your choices you make, and based upon your lifestyle, how active you are, how inactive you are, what kind of food choices you make. Now, once the diabetes is diagnosed, again, this lifestyle change is the foundation and the platform. We got to build up on this. So regardless of whether we cover that in our daily visit with the patients or not, lifestyle is the foundation, and that must be always addressed. Number two, we want our patients to be healthy, so we want them to exercise at a regular rate of at least 4 to 5 hours a week. They should consider any kind of activity at least for 30 minutes or 45 minutes a day. Having said that, now comes to the medications. Every type 2 patient should be tried on metformin because of so many beneficial effects. Unless they cannot tolerate, then we stop the metformin. If they can tolerate, then we use metformin as a foundation and build up on that, either as a dual therapy or triple therapy based on how uncontrolled their diabetes is. For the new onset diabetes, if the patient is coming in with an A1C of more than 1.5% above the target, which is 7% or less according to ADA guidelines, and the target or goal A1C according to ACE guidelines is to have it less than 6.5%. So if a patient comes in for the first time and their A1C is 8.5 or more, that qualifies them to be considered for either dual therapy or starting with metformin, but do not wait too long to add the second line therapy or third line therapy. There have been many studies that have been done on patients who have diabetes, and one of the concerns that we have is a lot of these patients get started on a medication and we don't change or add new medication for sometimes up to 3 years, and sometimes a third medication is not added up to 7 years. And what happens during that time is the uncontrolled diabetes or hyperglycemia is constantly hurting the eyes and the kidneys and complication risk of cardiovascular disease. So we're letting the patients stay in a hyperglycemic range. So whenever the patients come to us and they want to bargain or they want to do better with their lifestyle, I highly encourage them to give their best in the first 3 months. And if they cannot optimize and get their sugars under control, that is time to add another medication to get our A1C under control, and they could ongoing have effect or try to work on the diet and lifestyle and weight loss. And if that happens, then we can back off on their medications. So then comes to what are the different choices of medications. After metformin, there are various different classes of drugs that are available. My favorite ones are glucagon-like peptide GLP-1 inhibitor, and the second class is SGLT2 inhibitors. I prefer to use these medications earlier on in the diagnosis, right after metformin, if indicated. And then comes your other classes of medications, and insulin is usually the last one, unless you have somebody with a very high blood sugars, they're in a catabolic state, losing a lot of weight, their blood sugars are running more than 300, then we should start insulin earlier on. Also, on patients who are coming in with a new onset or A1C more than 10%, the oral medications and other options of treatment could be milder form, and they may not help us reach the goal. So we should consider insulin earlier on in those patients. So I hope this has been helpful to you. Please discuss with your doctors about your choice of therapy. There are much newer medications that have phenomenal effects on cardiovascular benefits, on preventing cardiovascular disease or preventing cardiovascular death from underlying cardiovascular disease with certain class of medications, and that has to be chosen based on your risk factors. Also, newer drugs have shown beneficial effects on your kidneys. So we like to use certain medications if you have underlying microalbuminuria or if you have underlying excessive protein loss in the urine. Having said this, we also like to address all the comorbidities of diabetes, and those include obesity, obstructive sleep apnea, those include hypogonadism in men. It could be anemia related to chronic kidney disease. So all those conditions should be addressed as well, but the main concern that we have is to prevent complications from happening. If somebody has the complications, then we treat accordingly. So everybody who has diabetes must know how are their eyes doing if they have diabetes affecting their eyes, how is their heart, if they have any underlying heart disease, if they need a stress test or not, how are their kidneys functioning, if they're spilling any protein in the urine, and if they have any kidney dysfunction. Also, we highly encourage oral care, and patients must get regular dental cleaning in addition to keeping regular eye exams once a year. The last one I wanted to touch was on the feet. You may have symptoms of neuropathy. Those could be reversible if you catch them earlier on and treat the diabetes accordingly based on your A1C. If we can improve the A1C, sometimes those symptoms improve. Also, we've seen diabetes, metformin can cause either anemia or B12 deficiency, and that can cause sometimes neuropathy symptoms that can worsen as well. So there are lots of things we can offer to make you feel better. Please talk to your doctor and get the right guidance, and be aggressive and be a team with your doctors or providers, because that is very important to reach to the next goal of success, not only to keep your A1C low, but also to prevent complications and live a very long, healthy life with diabetes not affecting any of your organs. I hope this was informational for you and you enjoyed the topic. If there's any other questions, we'll be happy to answer to our patients in the clinic. Otherwise, please give us a chance and we'll be happy to help you. Thank you. Take care.